The Gerontological Society of America, Meaningful Lives as We Age. Welcome to GSA on Aging.
Welcome to the Social Research Policy and Practice in Health Sciences GSA Series podcast on the Crisis in Long-Term Care, Episode 2, Moral Distress and What Keeps Me Awake at Night. I am your host, Deborah Dobbs. I'm an associate professor from the School of Aging Studies at the University of South Florida in Tampa, Florida. I have researched issues of quality and staffing related to assisted living for more than 20 years, with a particular focus on palliative and hospice care for persons with dementia, as well as disaster preparedness, which includes COVID and a recent National Institute on Aging funded study where our research team interviewed assisted living staff about their experiences during the pandemic. I am privileged to be here with our two expert guests to discuss the topic of moral distress in staff in long-term care. First, we have Dr. Ozcan Tunalilar, who is an assistant professor at the Institute on Aging and the Tulane School of Urban Studies and Planning at Portland State University. His research focuses on resident and staff well-being in long-term care. He co-authored a series of journal articles and reports describing the impact of the COVID-19 pandemic in assisted living communities, including one in the Gerontologist titled, What Keeps Me Awake at Night? Assisted Living Administrator Responses to COVID-19. That article was the inspiration for the title of this podcast episode. Second, we have Dr. Beth Galik, who is a professor and chair of the Department of Organizational Systems and Adult Health at the University of Maryland School of Nursing, and a nurse practitioner who specializes in improving care practices for older adults with dementia and their caregivers. She teaches in the Adult Gerontological Primary Care Nurse Practitioner Program and mentors doctoral students. She has served as the principal investigator on externally funded research grants that have focused on teaching caregivers in long-term care strategies to optimize function and physical activity and effectively manage behavioral symptoms with older adults with dementia. Dr. Galik continues to provide direct patient care to older adults with dementia and their caregivers in assisted living communities, nursing homes, and also has developed a house call practice for dementia symptom management. She is the editor-in-chief of Caring for the Ages and has served as past president of the Gerontological Advanced Practice Nurses Association. While COVID since early 2020 has affected residential care communities and nursing homes in devastating ways. For some information on assisted living, according to the National Center for Health Statistics National Post-Acute and Long-Term Care Study, approximately 25,000 residents died due to COVID and 445 staff between January 2020 and mid-July 2021. The smaller assisted living communities from the Midwestern regions of the country had higher rates of infection compared to the medium-sized assisted living communities, finding it challenging to social distance and care for residents in their home-like environments. There were challenges to get staff to comply with vaccinations once they were available. The Kaiser Family Foundation reports for all of long-term care staff rates to be at 82% vaccinated. And this is not specific to just assisted living, but both assisted living and nursing home. Sometimes it's challenging to find national data on residential care communities because federal data focuses more on nursing homes. So that's a good segue into my first question for our guest speakers today. First, I'd like to ask you, Dr. Galik or Beth, what are the differences between nursing homes and assisted living facilities?
Thanks very much, Deborah, and I'm pleased to be here with everybody today. It's interesting to kind of note, Ozzy and I will be talking about the differences between nursing homes and assisted living, but during the pandemic, the guidance that was put out was really designed for nursing homes and not so much designed for assisted living, even though assisted living facilities wound up following them. So nursing homes, also called skilled care facilities or skilled nursing facilities, provide a wide range of medically skilled services as well as personal care services. Types of things that are include nursing care, 24-hour supervision, meals, assistance with activities of daily living and recreational activities. Also, there's rehabilitation services such as physical and occupational and speech therapy. Some people stay in a nursing home for a short period of time after an acute hospital stay and then return home. However, there are many nursing home residents who live there permanently because they have ongoing or chronic physical or mental conditions that require consistent supervision and care. And payment of nursing homes includes private funds, long-term care insurance, and Medicare and Medicaid. And nursing homes have to follow state and federal guidance. And so I'm going to turn it over to Ozzy to tell us a little bit about assisted living.
Thank you, Beth, and thank you, Deborah, for that great introduction. So assisted living communities primarily cares for an older population who is at greater risk for COVID-19 impact. Around 80% of their residents are 75 years and older. And these communities typically provide room and board with at least some meals, 2 meals a day, and around the clock on-site supervision and personal care assistance with activities such as bathing or dressing or medication management. So in terms of distinctions between nursing homes and assisted living, I think the first thing to emphasize is assisted living communities are not federally licensed, but licensed by each state, which means there is a lot of variation across states in terms of not only how they are defined and what assisted living includes in the term in terms of size and services, but also variation in staffing requirements and admin qualifications, infection control measures, Medicaid funds spent on resident care and as such. When you consider all these variation across states and even within states across different assisted living facilities, that creates a lot of friction when it comes to one size fits all recommendation or rules that were being implemented, especially early on in the pandemic based on nursing facilities. Another distinction is what can be called in the philosophy of assisted living, so that social model of care and social engagement as core principles of assisted living. And when we kind of juxtapose those rules related to visitor and family restrictions and other rules related to infection control, I think the philosophy created a lot of situations for staff to feel the conflict on one hand to provide person-centered care, and on the other hand, follow rules and regulations around COVID-19 prevention efforts. And I guess the final thing I want to emphasize in assisted living is the staffing mix and levels and how different it is compared to nursing facilities in terms of limited nursing as well as kind of low or non-existing staffing ratios across states.
Well, thank you for that, for both of you, for those differences in the definitions and what services and the differences in staffing that both nursing homes and assisted living communities provide. Next, I want to ask, I'll start with you, Ozzy. You can go answer this first. What has been happening in long-term care facilities as the number of COVID cases has diminished, and why?
Yeah, thank you. So that's a great question. And I'd like to recast it in terms of what's happening now and looking back. So in my home state of Oregon, for instance, there were 167 active outbreaks in long-term care facilities as of this September. And that's not very different from last year's experience when there were 182 outbreaks. And this is a state, if you think about it, with 570 assisted living and 130 nursing homes. Now, of course, we got to acknowledge that total deaths per identified cases in these settings is lower thanks to vaccination and boosters. But these outbreaks continue to affect assisted living as well as nursing homes, their residents and staff 2.5 years later, with perhaps even increasing staffing challenges, lack of resources, and changing regulations, rules, and policies.
And do you think, just a quick follow-up to that, do you think with the different variants that they're more susceptible to infections, but maybe not as severe in terms of the symptoms and the illness? So you have just as many infections, but looking at hospitalizations, have those gone down?
I'll leave that to epidemiologists. I think one of the things we are seeing is, in assisted living at least, is this lack of data collection. And that prevents us to see clearly what's going on. And that's one of the things that is changing with this attitude of moving on from the pandemic. And, even at the beginning, assisted living data were hard to come by because of the state focus. But I would like to hear if Beth wants to chime in.
Sure. Actually, I would. And this is just based on my own clinical practice and experience and not so much on national data. But at the height of the pandemic, a lot of the places I practice are quite small. So they may only have 6 to 8, maybe up to 16 residents living in a site. And that's something that's much different from nursing homes that tend to be much larger. And often in these smaller facilities or homes, caregivers tend to live in. And so during the height of the pandemic, before the availability of vaccinations, those facilities went into kind of lockdown because they had caregivers living in the home. And they didn't get COVID, but they were isolated. Not necessarily in their rooms because they weren't having any outside exposure and telehealth was being used and families were restricted from visiting. But what we saw as people became vaccinated and things opened up were the places that hadn't been impacted before with COVID-19 infections. Those individuals eventually did acquire COVID, but they weren't as ill, and they weren't necessarily going to the hospital for treatment because there had been some time in advance to really address advanced care planning on whether or not hospitalization would be needed or not. So I think those are some of the changes that we've been seeing, but there continues to be outbreaks and facilities may not be, screening as much in terms of, testing before people are coming in. And we're relying more on, PPE that fortunately now is much more readily available.
Right. Good. And I think that's reflected in that, in my introduction with the data from, the palliative post-acute long-term care study, that it says that there's higher infection rates in certain regions of the country. I mean, it was kind of startling to me to see that they had higher infection rates in the Midwest, in the smaller, meaning 25 or less beds, compared to median size assisted livings. Okay, let's, along those same lines, how has the situation changed as the numbers of COVID cases went down in terms of what's going on with staff in these settings? And we can start with Ozzy.
Yeah. So every year we send out a survey to assisted living communities in Oregon. And early this year, we repeated that exercise and we found that 1/3 of staff had left in the past 6 months. Mm-hmm. And our interviews with assisted living administrators also suggested that some administrators were saying we can't find anybody because, people perceive this caregiving as a dying job, and then they haven't had the same people on the payroll in 2 consecutive payrolls, and this kind of increased turnover. I think it is what can be called the second wave of kind of resignations following the first wave, when people were being more. When staff were being more like, I got to protect my family. I can't be here. So this is more like after the burnout, what comes next, which is the high turnover. I mean, 1/3 of staff. That's quite high. And we actually found, our team found that there was an increase in the share of communities reporting a harder time hiring, retaining, and scheduling staff compared to 2021. And we also hear a much increased use of agency staff, which comes with its own problems, when you think about it, and some of which we can talk about.
Right. Do you think some of our interviews, because we interviewed 50 assisted living administrators in Florida, very similar to what you had done in your study in Oregon, and what we were hearing about staff trying to incentivize staff to stay, staff retention, they said one of the problems was the stimulus money the CARES Act money that was going to people during COVID, and they had people leaving because they were getting the unemployment and the extra funds. And so they figured, I can get that money and not work. I wonder, did you see any of that as a trend? That's what we had heard from some administrators.
We definitely heard it, and we tried to make sense of it. It seemed to come up in rural communities more. I can't say we have clearly identified it, but it definitely came up with our interviews with administrators in terms of why would they work here when they can just not work and still get paid at the same level or similar level that they are getting paid here, which is probably driving some of the wage increases that we are seeing.
Right. And Beth, do you have what do you have to add to that?
So I've kind of seen, at least at some of the facilities where I practice and have associations with, that the focus was probably a little more in getting people in the door with job fairs, hiring bonuses, etc., and probably less attention to retention. And I think that created this disparity from the staff who had been there all along versus the staff who were new, who were coming in. Some facilities that couldn't get staff actually were managing their census by closing beds or closing apartments so that they didn't fill them because they just didn't have enough staff to care for more residents.
Right. And then I know another that probably changed, and maybe we're going to talk about that in a later question, but the vaccinations, and did people leave because they were required to be vaccinated, staff? Were there mandates for vaccinations, and how did that play into that? And we can answer that later if that's a question.
Yeah, well, I was just going to say, in my experience, while there was some of that, I think that was more limited. I think that people who left eventually became kind of exhausted. And as Ozzy was saying, those two waves of resignations, with the second one, I think almost in many respects being worse than the first. Because these are long-standing staff who had been there a really long time and just became exhausted and wound up leaving. So I think less related to vaccinations, although sure there were some.
Yeah. Okay. Thanks. Now, how do regulations help or hinder with the staffing issues? Ozzy, you want to answer this one first?
Yeah, absolutely. So at the beginning of the pandemic, in the first year or so, the regulations and guidance and rules for assisted living communities were changing quite frequently. And many communities continue to report difficulties with keeping up with the changing information and conflicting information and trying to get family buy-in to understand and follow rules and policies and procedures. And we also heard about communities having a hard time getting residents out of their apartments for activities and dining and with the usual assistant types, requiring more staff now to address, those increased regulations or different regulations for infection control. So I think it creates this conflict. It puts staff and communities where there's a lot of opportunities for the kind of care that they want to provide against following the rules.
Sure. And I know we started out, and maybe Beth, you could speak to this next. We started out saying that the regulations, assisted living didn't have separate guidelines from a federal because they're state, regulated. They were following guidelines from the CDC and CMS that were really for nursing homes, and that conflicted in certain ways. If you want to speak to those differences.
Sure. I think when we think of nursing homes, they're probably one of the most highly regulated industries in our country today, down to like how wide your hallways are and the, how what the doors need to be made of, and all different kinds of things. And while assisted living doesn't really have those, because it really comes from a social model of care. And so those regulations aren't as significant. Also, in terms of staffing, in terms of licensure, you may not have a nurse who's present in assisted living. They may be in some of those larger buildings, but not in some of the smaller ones. And they may have a delegating nurse who's delegating tasks to direct care providers. So, it really is, quite different. And trying to meet the regulations for nursing homes, which are caring for a much more medically challenged community in assisted living that, really is a different environment, made it difficult.
Yes, definitely. And I'll follow up real quickly too. We talk about agency staff being used more in assisted living, and during COVID, agency staff going from place to place and coming into contact with more people, that would bring in more risk for COVID infections to the assisted living. That agency staff is something that they were essential workers. You were letting them into the building just like another compassionate care and hospice was coming into the building. And so, one recommendation our group made with some research we did was to, if they could, try to limit the number of assisted living communities that they were serving, that third-party provider home healthcare staff were serving during that time. So there wasn't so much, spread happening. And then we've already talked about the family role, which is much more prominent in assisted living than nursing homes. So making them, Candace Kemp's work is #more than a visitor, to restrict their visits. It really was a lot on the staff. So if there's nothing more on that, I'm going to move to our topic of moral distress. And if, Beth, you want to tell us what is moral distress and what causes moral distress?
Sure. I looked up a couple definitions of moral distress, and the one that I kind of liked the best because it was easiest to understand was from the American Association of Colleges of Nursing. And it says that moral distress occurs when you know kind of the ethically correct or the right action to take from your, training, but you're constrained from taking it by external forces that you can't control. And moral distress really threatens the core values staff members as well as, the communities. And it's distinct from other forms of distress experienced by healthcare workers, such as burnout and compassion fatigue. And it's because you know the right thing to do, but you can't do it. And so some examples would be, I had staff explain to me how they wanted to let family members who were such a part of the care delivery process and the support of residents into the facilities, but they couldn't because of the regulations. And they watched individuals with dementia, kind of deteriorate, and they didn't die from COVID, but, they maybe weren't eating as well, weren't interacting with others. So those things happened and kind of set up that moral distress because they knew the right thing to do was, to kind of provide this support, but they couldn't do it given the regulatory environment and dealing with this pandemic. I've heard other people describe how individuals with dementia would wander out of their rooms, which is kind of quite common. And, using person-centered care approaches, you may walk with them, make sure they have a mask, and then you're eventually taking them back to their room to try to engage in an activity there. But when some of the surveyors came in, facilities got in trouble for doing that, for, allowing even a few minutes for them to be out of their room while they redirected them back. And kind of hearing requests from some surveyors saying this person needs to be medicated so they don't come out of their room, which if they did that would be the inappropriate use of medications as a form of chemical restraint. So hearing these different things and really, it was these situations that caused, a significant amount of moral distress. Because they would, again, know the correct thing to do, but were stuck in this no-win situation.
Yeah, very good. Ozzy, do you have something to add to that? Other examples?
Yeah, I think Beth's examples are great examples. The structural part, I think, is kind of what differentiates, when you have lack of PPE and other equipment to follow, what to be good infection control practices, or when you just don't have enough staff to provide the care that that's needed. And perhaps I'm talking here from an administrator's perspective a little bit because of the interviews we had with them. But they describe these situations similar to what Beth was describing. How do you juggle responsibilities of wearing PPE all day in apartments that, residents wants to keep at 80 degrees, or, keeping your face shields on, getting foggy while you're trying to provide them with bath with a resident. So, all these things, I think, they come up with, and they are at times, I think, perceived, and they are in conflict with the kind of person-centered care practices that, some staff would like to provide. I mean, all staff would like to provide.
Right. And I looked up an article today, just some different examples, I think from the same site you just gave, Beth. And what's the opposite of moral distress is moral resilience. And how do we achieve moral resilience? And that is compromise to what's causing the moral distress. Ethical reasoning, that example you gave, well, go ahead and, you may be breaking the regulations by letting that person with dementia wander and, have their mask off, but doing the right thing, just making sure they're safe, staying away from others, but still letting them do that. And I was in assisted livings during the time when COVID was going on, doing some research, and that's what was happening on the ground. It's, she's going to wander. She's, we can't make her go back to her room. We could try 5 times. She's just going to come back out. We're not going to lock her in her room. We're not going to, so we're just going to keep her away from everyone else. And since she's not wearing a mask, and that just resonates with me in terms of how to get, reduce that moral distress. Okay, the next question is, what is the impact of facility closures? And I believe, Beth, if you want to start with this response.
So I think we're really at the beginning stage of this. And again, we have more data about nursing homes than we do assisted living. We know that a report was done by the American Healthcare Association and the National Center for Assisted Living. And we know that 300 nursing homes closed during the pandemic. And they're estimating, and this is where they're combining that nursing home and assisted livings together, that an additional 400 to 500 long-term care facilities are expected to close within the next year unless they receive more financial support. Because many of them were spending a lot of their funds on, buying expensive PPE and, bringing in resources and things for the staff. And they weren't having the admissions or because first people didn't want to come because everybody was kind of in lockdown at home. But then, later when they did want to come, when admissions were possible, there wasn't the staff available to care for them. So, I think we're going to be, faced with more challenges with facility closures as we, continue to move through. And while many people would like to stay in their homes, for it's not always possible or feasible. And, we can talk a little bit more about, what that would be like if we didn't have long-term care as an option. Home care, interestingly enough, has had even more challenges with staffing crises than assisted living and nursing homes.
Yes, for sure. I also, did you say, just to clarify, that there's not good data on closures in assisted living?
Not that I could locate.
I think you're right. I just think you can speak to that.
I looked. A lot of it was projections, and most of it really focused on nursing homes. Again, because there's not that federal,
right.
Kind of data collection. It's happening at the state level, or may not be happening at the state level.
Yeah, I think even pre-pandemic, the prevalence of assisted living closures and their impact, I think, was limited. Deborah, I think from your school there was a study.
Yep, I remember. Yeah. June and myself, but we had to use our state data. So to get that at a national level, there'd have to be someone in every state, or somebody could propose a study to go through. It would be a lot of work, but it could be an effort of many different institutions to, every state does track that, but it is not at a federal level.
Yeah, perhaps we can call out to our listeners here. That's a ripe area, especially in terms of the impact of these closures. If you think about like the substitution research between nursing homes and assisted living, and what happens when nursing home closes, and now what happens if both types of communities close, what would be the impact of that on communities? I think that's a ripe area for research.
I do too. And like you said, the home health is no better. It's a lot worse in terms of staffing. Okay. I think we've started to already talk about this, but what would a world without long-term care be like? What would it look like? We were just talking about that, but more on that. Beth, if you have more to add on that.
Sure. I think it would pressure families even more. Again, while many individuals would like to stay at their own home for care, sometimes their needs are just too complex, or families can't keep them safe, or have competing demands with work as well as childcare and other issues that make it too difficult to provide care at home. There are programs like the PACE programs that can be helpful in this, in trying to provide care at home, but there's not enough of them to go around to be able to really have a significant national impact. And family members would result in, really bearing that responsibility for the direct caregiving.
Right.
So I think there will always be a place for long-term care. And, we want to make sure that the good places are still with us,
Yes.
and, have the opportunity to stay in business.
Right. Ozzy, do you have something to add to that?
No, I support every word that I just said.
Right. In terms of, I guess could be the next question. We've got a lot of ideas here. So what can medical leaders do to help support long-term care staff and mitigate moral distress?
I'll start with this. So one is trying to make sure that your staff have the appropriate supplies to keep them as well as residents safe. And that also that there's appropriate staffing. And if you can't get the appropriate staffing consistently, that you consider downsizing in terms of your census. Because you won't be delivering good care, and you won't be able to keep staff who are faced with a resident care assignment that is just too large, given the human resources as well as the physical resources. The other thing I think that can be done is, be transparent and honest, and listen to the staff's concerns. You may not always have an answer, and it's important not to be defensive, but listen to what they have to say. The other thing that I've found that goes a long way is for those of us who may be in more administrative or kind of medical positions, to help. Rather than saying, if a patient you're examining as a clinician says to you while you're listening to their heart and lungs, I have to go to the bathroom, take them. You'll get a great opportunity to assess their gait.
Yeah.
And see their skin and other things, and it will be a help to the staff. And then let the staff know that you did that, so they don't have to come back shortly after and do it again. Or if there's someone who, needs extra help and, needs somebody to sit with or keep company with while you're doing your documentation, take that resident with you. Just the more that you can pitch in and let the frontline staff and the direct caregivers really see that their work matters, and that you're there to support them and to be a part of it, that makes a big difference. And then as an educator, I also want to encourage facilities that this is the time where you may be able to attract the next generation of healthcare providers into your facility. So I know we're worried about having students and other people come in, but we're letting visitors and other folks in. And so consider having your providers precept or provide clinical experiences for students and trainees, because they'll remember that. We want to give them a good experience and access so that they can be part of that next generation of care providers.
Yeah, that's very important. Ozzy, do you have something to add to this?
Yeah, I think it's I think those are all great suggestions from Beth. I think one thing would be to kind of focus on the core drivers of moral distress. It's, the difference between, is there training needed or are there resources needed? So focus on that structural part, right? Because those are the things that kind of admin management can be able to provide. So if training isn't the issue, if there's more core reasons behind the moral distress and the burnout, so because identifying causes is quite important, I think. And whenever in assisted living side, in our interviews, whenever we heard about happy administrators, they were the ones who had their kind of core team of staff who they got to keep. They were, they expressed they were lucky to have their backs. And I think I would be afraid that this third round of perhaps resignations or turnover is going to get into that kind of core teams of staff. And I wonder, I kind of worry about that future of staffing in that sense.
Yes. And then I've spoke just anecdotally to some nurse aides who have been there for a long time, but they are getting up there in age, the baby 60s, and I'm getting, this is physically demanding work, and I'm getting told to do this, and I need to do something else. So that's another, it might not be for that they had negative experiences. I'm sure it's always been challenging, but we've got to think of the cohorts of caregivers and get that next generation in there for sure. Next question and our last question, then we'll start to wrap it up. But what can families do to support staff?
So a couple things. One is staff don't like to be monitoring people and reminding people consistently related to infection control measures. So one thing families can do is, consistently follow the infection control procedures that are in place at the facility where your loved one lives. Another is to try to talk with the staff to find out the best way to do communication, particularly in times of short staffing. it may be difficult for staff to have time to return a phone call. So are there other methods of communicating? And maybe that's, coming to care plans regularly. Now, we've used technology a lot during the pandemic, and I think that's one of the little silver linings. People don't necessarily have to be physically present, but having opportunities for Zoom discussions in care plans that are already scheduled and happening. And just, when people don't get into caregiving careers because they want to hurt people, they get into it because they want to help. And so when you see staff doing something good or kind of going that extra mile, recognize that just with some few words to that person, or letting their supervisor know, or thanking them. Those things really can mean a great deal.
Yeah, that's very true. I just read a quote from a paper my doctoral student's writing her dissertation, and they had a good example of that the administrator sent out like Hero of the Week letters to the families of the caregiver didn't know it, but they sent them out to the family members of the person they were caring for. And then the family member would come in and say, "Oh, I heard that you were Hero of the Week." And it was a real surprise, like pleasant surprise to the staff. They didn't get the message. It was come from the family. So I thought that was a good example. Ozzy, do you have anything to add about family's role?
At the beginning of the pandemic, we had another round of interviews, and one of the things that were coming up is that when families were hearing from facilities, you can't come in, or there is no way you can see your resident. I think a lot of the frustration was directed at them, at the people and staff who were telling them these things. And I think I don't think staff agreed with some of those measures, but they were the ones who took the brunt of public's ire, perhaps. And they were helpful measures, but still it created a lot of friction in the relationship between families and staff and communities at times. So I think creating those communication channels, keeping them up, and just keeping in mind that everybody has, like Beth was emphasizing, everybody has the resident's best interest in mind. It is one way to be quite helpful, I think.
That's a good point. Very good point. So to wrap up, I want to ask both of you what you think can be done and how the public can support long-term care staff and any solutions to these challenging times for long-term care. Ozzy, if you want, or Beth, you go next.
Sure. So I think that the long-term care community has kind of suffered for a long time with a history of bad press. If you type in nursing home or assisted living and look at kind of the latest news articles that you see out there, oftentimes they're going to have a negative slant. And if you consider things the other way, think about during the pandemic when those working in hospitals and acute care setting were hailed as heroes, and they rightfully were. Whereas individuals working in long-term care facilities, even though they were putting themselves at similar risk and oftentimes working with less resources and less supplies to keep them and the residents safe, were kind of cast as the villains in this, even though that really wasn't the case. During the pandemic, a nursing assistant that I had worked with talked about how she stopped at the store while she was coming home from work and still had her badge on and was, kind of in her uniform. And somebody saw her from behind in kind of a nursing uniform and said, "Oh, are you working at the hospital?" And when she turned around, her badge showing she was at the long-term care facility, and the person, kind of said, "Oh, you're at the place where everybody gets sick," and being more derogatory. So just showing grace to people, and hopefully I would love to be able to get more good stories out there I know that there's a wonderful, wonderful book. I've shared it with my friends, and they said, now we understand why you like long-term care so much. It's called A Dog Walks into a Nursing Home.
Oh,
and it really talks about, the thing I love about it, I love dogs, but the other piece is it talks about how this public nursing home was really kind of part of the community. And I think, we need to start seeing assisted living facilities, other post-acute and long-term care facilities as parts of our community and not something that's separate, where the community is involved. So having things,
my students read that.
yeah, it's a great book, but having things like, volunteers come in and, offering space in the facilities for, the Girl Scouts or Boy Scouts to meet.
Yeah,
or
those intergenerational programs.
Yes. So there's lots of opportunities to really kind of have your facility be part of the community, but the community needs to respond as well.
Yeah, that's good. And last but not least, Ozzy, do you have any final concluding comments or thoughts?
Yeah, I agree with what Beth said. And I would also say, just to conclude, the COVID-19 pandemic has been an awful and quite trying experience for assisted living and nursing homes, all residential care. But one silver lining could be that if we could keep the discussion, public discussion as to what kind of long-term care do we want in the United States, and having that now rather than later. And, even now we might be a bit late, but keep having that conversation, I think, would be one support I think public would have. How do we fund it? How do we channel enough resources to these communities so that they can thrive and, take good care of our older adults and people with disabilities?
Yes, very, very good comments. Well, I thank both of you for speaking on this issue today, and we will end there. Thanks again for listening.
To learn more about the Gerontological Society of America, visit geron.org. The Gerontological Society of America was founded in 1945 to cultivate excellence in interdisciplinary aging research and education to advance innovations in practice and policy. For more information about GSA, visit geron.org.